CIRCA-DOSE trial was a multi-center randomized prospective clinical trial conducted at 8 centers across Canada. This study enrolled patients with highly symptomatic paroxysmal atrial fibrillation who are deemed candidates for an atrial fibrillation ablation procedure. At the time of enrollment, we put loop recorders in every patient to monitor their atrial fibrillation burden. Approximately 2 to 3 months later, they were randomized to contact force-guided RF ablation or to cryoballoon ablation using 2 different doses. And then they were followed for a year following ablation. As I mentioned, all patients had a loop recorder to judge for arrhythmia outcomes. Safety outcomes were prospectively tracked. In terms of the cryoballoon arms, we used 2 different dosing strategies, so the standard being a 4-minute freeze with a single bonus application. We also included a short duration arm, so a 2-minute cryo application with a 2-minute bonus application. The inclusion of this arm was based on previous preclinical work, which showed that the lesion characteristics were very similar with 2-minute lesions compared to 4-minute lesions. And so we wanted to evaluate this in the clinical realm. In order to be robust and relevant, we also had an RF arm as our standard of care, using best practice for contact force-based ablation. And so the study essentially compared those 3 different treatment strategies with a view to safety and efficacy outcomes. So the CIRCA-DOSE is one of the most robust trials performed to date, largely based on our arrhythmia adjudication. So every patient received a Reveal Link loop recorder, so every patient had their rhythm monitored in the exact same way. Those tracings were transmitted on a daily basis and then weekly manual transmissions. All of the arrhythmia episodes were independently adjudicated by a blinded committee. So we had 12 adjudicators who went through 65,000 transmissions and judged whether it was atrial fibrillation, flutter, atrial tachycardia, noise. So we have a very robust evaluation of the arrhythmia episodes. In addition, the continuous cardiac monitoring allowed us to assess atrial fibrillation burden, so we can tell how much atrial fibrillation people were experiencing in terms of hours per day or percent time in atrial fibrillation. Because we implanted the devices prior to ablation, we have a baseline to assess and compare to the post-ablation state. From a rhythm standpoint, it's probably one of the most intense evaluations of the outcomes of ablation performed to date. So atrial fibrillation burden was assessed using the use of continuous cardiac monitors or implantable loop recorders. So we know with paroxysmal atrial fibrillation, it's an intermittent problem, meaning that episodes are not present every day. Their episodes come and go. The biggest limitation of trials performed to date is the use of intermittent monitoring with things like Holter monitors, meaning that if the atrial fibrillation wasn't present the day you monitored, then you'd say there's none there. This leads to a big limitation in terms of judging the outcomes of patients following ablation. So by having the monitor in place 24 hours a day throughout the entire treatment period, we're able to get a true assessment of the amount of atrial fibrillation patients are experiencing, and therefore allows us to actually assess burden, which you can't monitor with intermittent techniques. Because we were comparing different technological solutions for atrial fibrillation ablation, we wanted the most robust outcome that we could have. So the primary outcome for our study was any atrial arrhythmia, whether it was atrial fibrillation, atrial flutter, atrial tachycardia. If that occurred between 3 months and 12 months post-ablation, then that constituted a treatment failure. Likewise, because we were doing a comparative technological evaluation, we considered reablation at any point to be a treatment failure and constituted a primary endpoint. The secondary endpoints of our study looked at things like symptomatic arrhythmia and overall atrial fibrillation burden. So when we take this study and we look forward in terms of the long-term or the clinically relevant endpoints, I think it highlights the stark difference between the HRS Society mandated time-to-event type endpoint and what's important to us in clinical practice. When I see a patient, an equally valid commentary based on the results of CIRCA-DOSE is to tell them that they have a roughly 50-50 chance of having atrial fibrillation again in the next year. But I think that misses the overall treatment effect. Because if we look at burden, I can tell them that I can reduce that burden by 99% following ablation. And so if the burden reduction is 99%, that's a very different thing to telling them that they have a 50-50 percent chance of success after an ablation. Likewise, when we look at symptomatic arrhythmia, which is the relevant outcome to the patient, we had an 80% success as opposed to a 50% success. So I think that the biggest takeaway from the CIRCA-DOSE study is that when we use robust rhythm monitoring techniques, it tells us different information compared to what we need as clinicians.